It actually is a fun way to go, because what I've learned over my career is that geriatrics is very osteopathic. It's very osteopathic because it's not a solo sport. You need to work with your team members. You need to work with nursing. You need to work with families. You need to really approach the person from a very holistic standpoint. There's a lot of very interesting interactions. And one of the things that I've learned over the years is actually as you decrease medications, patients get better. That it's not necessarily more is better, and that's really what you're going to see here. So this is not a new concept, and these are the learning objectives that we're going to go over. So really, when you think about geriatrics, geriatrics is actually a relatively new field. It's not even 50 years old. The first any inkling of anything having to do with caring for older adults doesn't appear until the federal government comes up with the Medicare and Medicaid Act in 1965. But you don't start seeing like the National Institute of Aging forming until the early 70s. And geriatrics as a specialty doesn't start to even get moving until the late 70s, and you don't see the first fellowship programs until the early 80s. So this is still very new in the House of Medicine as a subspecialty area. So basically, when you talk about geriatric prescribing, everything is new because we're constantly learning. And if you think about the pharmacology that all of us use in this population, these drugs are tested on 40-year-olds. We really don't have good grasp of understanding of how the physiology and drug metabolism works in a 78-year-old, in an 80-year-old, in an early 90-year-old, and in a late 90-year-old. One of the things that I've often monitored socially is the Today Show. So for those of us who remember Willard Scott doing the weather, he would have a couple people every day who had just turned up to 100, and it was sporadic. It wasn't every day he would have that, but there were a couple people. NBC now reports that they have too many people that they can't, who are turning 100, that number has blossomed to the point where they can't get all of those people on TV. And I think that speaks to changes of medicine, changes in the way we take care of ourselves, and somewhat about just how we're prescribing. So the term prescribing cascades, who's heard of that term? Great. So prescribing cascades is a term that first appeared in 1999. It's still a very hot topic. And we'll talk a little bit about prescribing cascades today. You know, antipsychotics became a very hot issue in terms of prescribing in older adults in 2010. This is when the data on cerebral adverse events came out and the black box warnings on all of the antipsychotics, and CMS policy against use of antipsychotics in nursing home patients. In 2015, literature started coming out saying that actually more dangerous for this population than antipsychotics is actually benzodiazepines. Did anyone know that? So the data is pretty damning, actually. The entire class seems to trigger strokes in the older adult population. So that's why, for those of you who are lucky enough to watch me write this on your consults, I put in capitals, no benzodiazepines, because this is far and away the worst drug you can prescribe to an older adult. And then this is the hot new term that came out just at the beginning of the pandemic. I think Dr. Fauci kind of eclipsed the literature that started coming out on this, and this is the term deprescribing. And deprescribing, in my opinion, is a very osteopathic content, and we're going to talk about that today. So this is a very serious problem. We've known for a long time that older adults are using a huge amount of prescription medication. And it seems that most older adults, people 65 and over, are taking 14 or more medications. And what's not well understood or well tracked is how many herbal supplements people are actually taking. And there's a lot of drug interaction between herbal supplements and prescription medication. The problem is because the herbal supplements, for the most part, are widely unregulated, we don't really understand all of those interactions, but it's creating real havoc with the geriatric population. So in general, all of this is not a new topic. It's actually a very old topic, and it goes back even to the origins of geriatrics as a subspecialty, because the Archives of Internal Medicine had an article published in 1986 talking about the dangers of prescribing and over-prescribing in older adults. 25% of all prescription drugs in 1986 were taken by people over 65. Older women took about almost 6 medications a day, and there was a very firm understanding going back to 86 that the more drugs you take, that your side effect rate increased. But yet we all still do that. I think that's the definition of insanity, is doing the same thing over and over again, expecting a different outcome. In 2015, National Public Radio out of Boston did a whole story on the danger of prescription medication, so the public started getting a very big awareness that this was a problem. But at the same time, in spite of Medicare's warning and guidelines to reduce prescription drugs in long-term care, you started seeing a push to treat older adults with psychiatric drugs. Huge spikes in the use of antipsychotics, benzodiazepines, and antidepressants. And it's not really clear exactly why. Some of it is thought to be due to the Medicare D system and their favoring of the use of certain drugs and their very complicated and, unfortunately, my opinion, unethical relationship with the pharmaceutical industry. Because if you think Medicare D is protecting our older adults, you're sorely mistaken. In 2017, and I think this is all interesting because it's all pre-pandemic, and then you basically have this blip, for those of you who are Marvel fans, that happens for 2 years at the end of 2019, beginning of 2020 till now, where the focus really shifts into infectious disease and away from issues such as this. But the New York Times picked up an article and put this out. This is scary. This is totally frightening to me, that retirement-aged Americans, notice the change. We no longer start talking about people 65 and over. We're now talking about people of retirement age, which pushes that number way beyond 65, and I think is probably a more accurate way of referring to this. At least 3 psychiatric drugs, and that doubled from 2004 to 2013. And no mental health diagnosis. WTF, gang? I mean, this is like seriously problematic. And here's what this kind of looks like. So, I'm gonna go over here. So the gray are younger Americans, and the clear rectangles on the histogram are older adults. So if you look at mental health diagnoses, the younger patients have lower incidence, as you would expect, of rate per 100 of the population of mental health diagnosis. And in terms of taking active psychiatric medications, these are the younger patients. The younger patients are seeing more psychiatrists than their older counterparts, and they're going to therapy slightly more, but not statistically significant change. The standard error bars overlap here. The standard error bars just miss each other under seeing a psychiatrist. But here's where it gets strange. There is not really a statistical significant difference between mental health diagnosis in the younger population surveyed and the older adult population. Again, the standard error bars overlap. But look at this use of psychiatric medication in the older adult population. And I think that's what we're going to talk about a little bit more here. So I already gave away the answer to this, but the worst drug group based on, this is a very large scale, probably our most complete data coming out of what is happening in prescribing, especially psychiatric medications in older adults, came out of the University of Michigan. And they looked at CDC data and US Census data at over 100,000 office visits. So it's a very large sample size. And the worst drug group is far and away the benzodiazepines in this population. Not only most overprescribed, but most dangerous. Because in an older adult, it contributes to falls. A hip fracture in someone who is 80 or greater is game over. Life expectancy then becomes about 6 months. Increased incidence of death, mainly due to stroke in this population. Double the risk of motor vehicle accidents. Dr. German and I just yesterday were talking about other substances and the rise in motor vehicle accidents, but think about this. Older adults who are driving, and you know, this is New Jersey, it's our God-given right to have a driver's license and a car. You're over-medicated and you're getting into accidents. And benzodiazepines, because they work on the GABA system, are implicated in depression. So you're giving patients pills and you're creating other mental health problems. And we know that benzodiazepines with prolonged use may contribute to dementias. Certainly they contribute to delirium in this population. So this is a study done in 2014 looking by age group of benzodiazepine use and prescribed by primary care versus prescribed by a psychiatrist. And I think this is really kind of interesting to look at as well. So in the 18 to 35 group, you're seeing about a 2.6% prevalence of benzodiazepine prescription, and 15% of that is prescribed by the psychiatrist. In the 36 to 50 group, you're seeing about 5.4% usage and slightly less prescribed by a psychiatrist, 12.8. But here's where it starts to get dangerous and I think concerning, is that in the 51 to 64 box, you're now seeing 7.4%, and then most concerning is the 65 to 80 age group with 8.7% prevalence of benzodiazepine prescriptions, but almost 5%, slightly more than 5% are prescribed by a psychiatrist. So there was a really interesting study, again, a year before the pandemic, February 8th, 2019, that comes out, looking at osteoporosis and hip fracture and psychoactive medication prescription, which you necessarily wouldn't put together, but in geriatrics, and for those of you who are geriatricians, we think about this all the time because it's what you see every day. So when you start looking, and this is a very good sample size, you're looking at almost 5,000 people with osteoporotic fractures, and about 1,700 people who actually have hip fractures. And you can see in this age group, greater than 85, you're seeing about 1,000 here, about 21%. 42% are in the 75 to 84-year-old group. And in this study, 78% of the people with fractures, osteoporotic fractures, are women. But look at this. With major osteoporotic fractures, 25% are on benzodiazepines. And with hip fractures, almost 30%, 28% are on benzodiazepines. This isn't do no harm. This is actually, we are doing harm. So the next works class after benzodiazepines are really the antidepressants, which is kind of the surprise here, right? And this is why I started out by saying everything in geriatric prescribing is new, because we're starting to learn a lot about classes of medications that have been out. Now, we've always known the tricyclic antidepressants, the first class that came out in the 60s, were dangerous. First degree AV block, they're highly anticholinergic, so dry mouth, dry eyes, decreased saliva production, increased dental caries, constipation, urinary retention, and they're lethal in overdose, so it's nothing better than giving your depressed suicidal patient a loaded gun with bullets and say, here, take one every night, but if they take a fistful, they may be lucky enough to get into an ICU and hopefully not lucky enough to get into the cemetery. That was the real problem with tricyclics. So the SSRIs came out in the late 80s, early 90s, and here's the problem. We start seeing increase in blood pressure. Hyponatremia is a huge problem with SSRIs. How many of you are looking at sodium levels on your patients who are taking SSRIs? How many of you are seeing hyponatremia? Right. We do not re-challenge patients who have hyponatremia from an SSRI. We're done. Were you asking a question? Okay. There's a bleeding risk with these drugs. So, you know, so while safer in overdose, NSRIs and SSRIs, clearly safer in overdose, not great drugs. And there's a huge opportunity as osteopathic physicians here, because what we generally do is the patient saying they're depressed and they get a prescription and they walk out the door. But the real opportunity is you look at exercise, you look at nutrition, you look at what else is going on. Is it an anniversary of a death? Is there a recent loss? Is there marital strife? Is there a relationship problem going on? Are there problems with the kids? And you start going down the holistic view on the patients, and you can sometimes make some very significant inroads here. Maybe they're in severe pain, and pain is masquerading as depression. Maybe they're having some memory loss, and that's making them feel depressed, and we need to do a dementia workup on the patient. So, you know, what about the patients, though, who have dementia, and you're getting the phone call from the family, or you're getting the call from the long-term care or the assisted living nurse saying, you know, my dad's very depressed and we can't take the crying all the time. Or, you know, Mrs. Smith is just so anxious, she won't sit still, she's pacing all over the place, we need something. What do you do about those things? So, this is the truth, gang. Study after study shows that the antidepressants and the benzodiazepines in dementia for depression and anxiety, for the most part, don't work. You're feeling good because you're doing something, you're giving something to the patient. Nursing staff feels great, or family feels great because they're passing a pill to the patient. But the reality is, you might as well be giving placebo. The risk of giving 10 to 12 medications to someone with a failing brain, and brain failure is probably the better term for dementia and a term that keeps trying to make a comeback, the risk is much, much greater than the benefit. Again, these drugs are studied in 40-year-olds. They're not studied in people in their mid to late 80s, 90s, or 100. We don't have good pharmacologic data here, or outcomes data. So what about the other classes? The antipsychotics, there's a very well-defined literature here. We know that these drugs are commonly used for aging and dementia. CMS had a goal of reducing these drugs by 30% in nursing homes. This is tied to the star ratings. I'm going to talk about that in 1 second. But in general, the elderly are much more susceptible to the side effects of these drugs. And even though we don't talk about it, which is why I'm talking about it with you today, extrapyramidal symptoms, tardive dyskinesia, and neuroleptic malignant syndrome are still major concerns. I had a nurse practitioner in a long-term care, in an assisted living setting, prescribing quintiapine to an 80-year-old. And the nurses, said, I don't think they're much better. And can you go see them? And I go see them. And the patient I saw had a 99 fever, and she was a little stiff. And I went back and I ordered a CK, and I said, see if we can get a urine, and I want a myoglobin screen on the urine, because I think we've got NMS starting here. The nurse practitioner DC'd the orders. I called the nurse practitioner and I said, why'd you do that? And she said, well, she's not having a heart attack. And I said, I'm worried about NMS. And she said, what's that? This is why, gang, if you were here for my presidential speech, we have to contribute to JOPAC, because we're the ones that have the education and the experience. And we have to take that message to Trenton, because it's scary. And I see it, many of you see it, if not all of you. So I want to get to this point. So on the Sunday after Labor Day in September, this past year, the front page of the New York Times had an article about nursing homes and use of antipsychotics climbing, and how the inappropriate use was out of control. And it's a very damning article on the nursing home industry. So I'm not sure how many of you are aware, I know Dr. Fine is very aware, that CMS tied antipsychotic use into their star rating system. So everyone wants to be a 5-star facility, and the way you do that is by minimizing antipsychotic usage and doing the reductions, and you're not having sentinel events, and there's a whole host of other things. But what nursing homes did is they figured out there's a loophole in that, so that if you're giving antipsychotics for major psychiatric illness that they're indicated for, schizophrenia, schizoaffective disorder, bipolar disorder, you can use as many antipsychotics as you want, because they're not on the report to CMS, they're exempt. So here's the problem. What age is the maximum that you're going to develop schizophrenia? You didn't know there was a quiz, sorry. It's 9 o'clock, so I think it's fair to ask quiz questions. What's the oldest person that's going to be newly diagnosed with schizophrenia? 35, 20-ish. So it's 35 to 40. 40 would be the upper limit. So grandma or grandpa developing schizophrenia at 85, I can tell you 100% bad person prescribing for that if they're saying that's schizophrenia. Bipolar disorder, what's the upper age limit? 30, I heard 30, going once, going twice. Sold. So it is 30. I've seen 35, but it's early to mid 30s. Great job. Mom or dad getting bipolar disorder at 78, I can tell you with 99% certainty isn't happening. And here's the problem, and it was in the New York Times article. Family members get a list of drugs and the diagnosis. And now the family's freaking out because mom or dad now has schizophrenia, and the family has Googled this and realized there's a genetic correlation, and now are my kids at risk of getting schizophrenia? And through the magic of Epic and every other EMR system, when the patient gets transferred from the nursing home to the emergency room and then gets admitted because they have sepsis, the schizophrenia diagnosis from the nursing home is now lifted, put into Epic, and now it's on the hospital chart, and now they're consulting psychiatry for the obtunded 80-year-old with schizophrenia, and I get to write, patient does not have schizophrenia, no mental health history, and the family's happy, and the nursing home's furious. Thank God that New York Times wrote this article, because now the state inspectors are cracking down on inappropriate diagnoses. And if you stay for the panel discussion that's coming up, we're actually having someone from the state nursing home diversion plan program, and we talk it's called ESCOPE, it's run out of Trinitas Hospital in conjunction with Rowan. We talk almost weekly about inappropriate psychiatric diagnosis on nursing home patients we're seeing and the consequences of it. It's not isolated. And the New York Times article cited multiple facilities across the country. What was very concerning was they interviewed a medical director who actually would take the chart, not even the patients they're seeing, and would go through and change the diagnosis to match the prescription. That's a problem. I think Dr. Levine might agree with me that we would call that fraud. So what about the other classes of drugs that we give? You know, sleeping agents, you know, they cause drowsiness, that's what we want, but that contributes to falls. We know with Ambien, we've heard the stories and seen the reports and the case studies of blackouts and sleepwalking and sleep eating. The American Medical Directors Association and the American Academy for Sleep strongly advocate sleep hygiene, only using sleeping agents for 2 weeks and avoiding benzodiazepines for sleep. My biggest complaint, which isn't in their report, but it's something I see routinely and I've spoken here about, is the use of quintiapine for sleep. Because here's how that goes. Doctor, are you aware that quintiapine is an antipsychotic? Yes. Are you aware, doctor, that antipsychotics cause neuroleptic malignant syndrome? Yes. Doctor, are you aware that neuroleptic malignant syndrome can result in death? Yes. Okay, case closed. NMS is not dose dependent. We've seen it at 25 milligrams of quintiapine. I've seen it at 50. It's not dose dependent. And what about the acetylcholinesterase inhibitors? So I remember when these came out, I got into it with one of the pharma reps who told me these are the safest drugs on the market. And I said, well, then why does your package insert say otherwise? And they said, no one reads that. True, very true story. So we know the risks may outweigh the benefits with this class. We know that there are issues with dizziness. Bradycardia is definitely an issue. How many people have seen bradycardia with patients on Exelon, Aricept? Yeah, the treatment is easy because the treatment with all of these is side effects with the acetylcholinesterase inhibitors is you back the dose down or stop the drug and the problem goes away. So it's relatively easy. What's subtle, I find, is the anorexia because it's a 1 to 2 pound weight loss a month. So over the course of 2-3 months, not really bad, but over the course of the year, you can be down 24 pounds, which then could be a sentinel event, and then it affects the star rating, and then people aren't happy. And the agitation, in my experience, appears to be tied to decreasing brain function, steady state of the acetylcholinesterase inhibitor, too much acetylcholinesterase inhibitor, not enough brain function, so you need to drop the dose. But what we see is patients get prescriptions for the agitation rather than pulling the drug back. And that's the prescribing cascade. So deprescribing, which I told you is the hot new term, reduces costs, it reduces length of stays in hospitals, and it decreases overall utilization. So why wouldn't you want to do this, right? So I want to talk to you about a real case, Mr. S. He was living at home with his wife, and he was failing. One day, his wife would go out shopping. He'd ask her where she'd go. She'd say shopping, and she'd come home with food, with groceries, and he wouldn't believe that she went to the supermarket. And then one day, she left clothes fell out while she was folding on the couch, and he found his clothes, and so then his delusion started that she was cheating on him. And he threatened his wife with a knife. She called the police, as, makes sense. And he was involuntarily admitted to a psychiatric hospital, which doesn't make sense. But that's what happened, and we'll talk about that, not about this case specifically, but we'll talk about similar instances in the next session. So when Mr. S goes to the hospital, this is what we know. He had hypertension, osteoporosis, he had a dementia for 6 years, hyperlipidemia, and GERD. That's what he had. He had no psychiatric history. He was married to his wife for 53 years. He was a retired Air Force veteran. He had been an attorney, which doesn't add much to the case other than highly educated. This is certainly not another doctor-attorney joke. 3 kids, 5 grandkids. He likes gardening, biking, hiking. Very active gentleman, pre-morbid. He and his wife enjoyed a cocktail with dinner, not every day. He smoked some weed in college. The wife said, who didn't? And no cocaine, no opiate history. But per his wife, he was abused by his stepfather, who was a boxer. So not only did he suffer physical abuse, verbal abuse, he was physically abused as well. And these are the medications he goes into the hospital on. And I'll read in case you're missing the bottom. So lisinopril, Lipitor 20, Nexium 20, and Aricept 23. So nothing earth-shaking here. So the hospital refers him to a dementia-assisted living who refused to take him due to the reports of violence on his hospital chart. And they referred him to the behavioral management unit. Quick review, I know we've talked about this in the past. State of New Jersey runs 4 behavioral management units in nursing homes. These were developed by the New Jersey Institute for Successful Aging at Rowan 25 years ago, 30 years ago now. The 4 units are north to south. The Christian Home in Wyckoff, the Preakness Center in Wayne, Absecon Manor in Absecon, just over the bay, and the original unit is at Silver Care in Cherry Hill, and that's the unit the university designed for the state. So, and I happen to be their medical director, so I reviewed his notes. His notes from the hospital say he's violent, severely aggressive, unpredictable, and assaultive. And it says that over and over and over in his notes. Yelling and screaming, very paranoid. Okay, I'm thinking, bring him on. This is like the perfect case. This is what the behavioral units are for. So I'm all excited. Except when Mr. S arrives at the behavioral unit, he's incredibly lethargic. He's non-ambulatory. You can't wake him up. And I meet with his wife, who's hysterical crying. The patient in front of me is not the patient in the notes. They're two very different patients. And you almost wonder if the hospital was copying and pasting notes because none of the behaviors described, even the day before, reflect the patient that we're seeing. So on his discharge sheet from the hospital, these are the gentleman's diagnoses. You know, I'm just thinking about this. I should have done this. Here are his original diagnoses from being at home. This is what we're getting. So without even looking at him, there's no way this gentleman has paranoid schizophrenia or bipolar disorder, based on what we all agreed on earlier. What's more disturbing, I could agree with dementia with behavioral disturbance, given he threatened his wife with a knife and, you know, he's paranoid, but more disturbing is these are his medications. This is New Jersey, gang, in 2020. This is criminal. Okay. Can we go on? So, here's what we did. We stopped his Risperdal, we stopped his Namenda, we stopped his Depakote, stopped his Ativan, decreased his Aricept from 23 to 10, decreased his Celexa from 40 to 20, and decreased his Trazodone to 100 milligrams as step one. You have a lethargic man who's lying in bed who looks basically like this. It's a good thing he was still breathing. A week later, he's still lying in bed like this. So we've seen no change with deprescribing. So here's where we stop his Adderall because it's not waking him up. I don't know what the stimulant's doing, other than, I don't know. And I decreased his Clozaril from 3 times a day to twice a day, starting to peel that back. So remember, I should go through this. So the problems here, among many, is, this is probably too high. I'm not sure. I have no blessed idea why he's on a long-acting stimulant twice a day. I don't know why he's on a mood stabilizer. I don't know why he's on 2 antipsychotics, because the guidelines are not to put patients on 2 antipsychotics. 40 of Celexa I could take or leave, but you go back to minimal effect in dementia, not sure. Ativan 2 milligrams TID is a great recipe for fractures, and 200 of Trazodone in HS If the clozaril, risperidone, Depakote aren't putting this guy to sleep, I'm not sure what 200 milligrams of trazodone is going to do. So this is his new med list. So you're following along. So 2 weeks later, he starts to wake up, and he's more alert, and we're seeing no paranoia and no aggressive behaviors, so we further de-prescribe on this gentleman. We decrease the Aricept from 10 to 5, take the clozaril from 50 BID to 25 BID, and decrease the trazodone now from 100 to 50. So we have a family meeting with the wife, and now she's talking about going to the assisted living she wanted to take him to because the assaultive, aggressive, unpredictable, really mean, nasty, you don't want this person in your facility is no one that we've found or met. And the wife is very upset because she said no one at the hospital listened to her the way the team at the behavioral unit was listening to her. And it's, honestly, it's kind of sad, right? Because the family is an important partner in the care here. The patient's not giving you any information. So in terms of prescribing pearls, you really have to review if medications are working or not working. And while it sounds intuitive, I know in the course of a busy practice, it may not be obvious to stop and pull medications that aren't working before you're adding medications to see if they're going to work. But to keep medications on board that aren't doing anything, which may have been what happened with Mr. S, just creates toxic soup. The use of inappropriate medications is a very real problem. It's a growing problem, and it's something we have to be really careful about. And you have to think about removing drugs that cause side effects. So I want to just go backwards for a second in Mr. S and tell you how I would approach this. So the wife is saying here that he's threatening and he's becoming agitated and suspicious at home. Okay? And she can't reassure him. What I probably would have done pharmacologically is, this is really sensitive, is decrease the Aricept off the bat. Because the 23 milligrams may have just been way too much for him at that point where he was, and probably would have first gone to 10 and seen how he was doing in about a week to 2, and then maybe go to 5 or pull it altogether. But doing this, I would never do. So as I started out by saying, what I like about this topic is prescribing in geriatrics is very osteopathic. And you don't need me to tell you, you all have the tools. You inherently have the empathy, you have the wisdom, you know how to effectively look at the whole person. So I see this as more of a gentle reminder that we can all do this together, and we do provide much better care, and I would be incredibly surprised if anyone in this room would have a patient who is on a drug list like that. Any questions? Yeah. Very carefully. So the question is the 82-year-old woman who comes in on and been on Xanax for a long time. So first of all, one of the weird things about Xanax, so you know, you all know this, just quick reminder, short-acting, renally cleared benzodiazepine. So one of the problems with the renally cleared drugs is that you have to really monitor renal function, because if someone's in CKD, the drugs are not being metabolized correctly and you could be running into toxic issues. Xanax in psychiatry is not what we would call a gentle drug. Patients very commonly describe, I can feel it start working or more commonly kick in, and I can feel it stop working. And then they start craving the next pill because they can actually feel it stop working. And over and over, patients say the same thing. So that's one of the harder things to do, is to switch someone off Xanax. But looking around the room, most of us remember, there are conversions on benzodiazepines. So one fun trick is to switch someone from Xanax to Cerax, oxazepam, which is the active metabolite of diazepam. Or you can switch them over to lorazepam, assuming renal function is fine, because these are the renally excreted drugs. And you can, if you look at the conversion table, you can put them on the dose of the corresponding agent so that they're not going to experience the withdrawal. The problem with Xanax is you're going to be fighting with your patient who's going to actually like the feeling of it starting to work and stopping to work. And that's why I don't start patients on Xanax in the first place. Paul?
Excellent talk, but the but is coming. You knew the but was going to come. I heard a lot of negatives. I didn't hear a lot of positives as to what to do with some of the patients who demonstrate behaviors like this we all encounter. Let's say we stop or reduce the Aricept on this gentleman, and the paranoid and aggressive behavior continued. What would we do next?
So, great point, and thank you for bringing that up, because you're absolutely right. This is a lot of don't do this. So what do you do? So part of the fun thing in geriatrics is if you go back to, we don't understand the physiology, and we don't understand the drug metabolism. I'm still being negative, I know that. It gives you opportunity to do things you wouldn't normally do. So if you have a caregiver, so say Mr. S is still paranoid with the reduction. So you need the wife as your partner. So what we know is the best geriatric data on antipsychotics surrounds risperidone, olanzapine, and clozaril to a lesser degree, but risperidone and olanzapine. You could do a short burst of either of those drugs, maybe for a week or two, see if the symptoms change. If the patient is too lethargic, because he's not a big guy, you could dose every other day, and with the wife as your partner, if he's still too lethargic, you can dose every third day, which isn't something we inherently think about, but it's something I do a lot of in geriatrics. So short bursts of drugs, but the key is not to keep people on drug long term. It's eliminate the symptoms and then see if you get symptomatic return. And varying the dosing, so you can throw everything you know about how, BID, TID, QD out the window, and you can dose very differently in this population with great success because their metabolism is different. But this is one of the downsides of telehealth right now, is that you don't get to see the person in front of you. So you don't know if the person, looks like you and me, Paul, or if they look like they're cachectic and emaciated, because you may only be seeing them from here up. And obviously someone who's cachectic needs much less medication, and someone who maybe hit too much Haagen-Dazs over the pandemic may need more frequent dosing because their the fat distribution is different.
Thank you.
Great question, thank you.
You mentioned olanzapine and risperidone, but you chose to continue the clozaril, which is a little more difficult, expensive, et cetera. Why'd you do that?
So I stopped the report on him. He ultimately came off clozaril. We were able to get him off of that as well. Clozaril really is the antipsychotic of last resort, very well supported in the literature, even in older adults, for patients who have failed multiple antipsychotics, very severe aggressive patients, frontal temporal dementias, Lewy body disease, where they'll have atypical response to any other antipsychotic. They respond well to clozaril. Clozaril, if used correctly, can be a really great drug in geriatrics, but you're also using microdosing. So a clozaril in a bipolar or schizophrenic patient, you might be dosing 400 to 600 milligrams a day. In a geriatric patient with a frontotemporal dementia or a Lewy body disease, you may be on 25. I have one patient on 12.5 milligrams a day. They're microdoses, to Dr. Morris's point earlier.
What happens when we have the patients, like I do have a patient who is 85, he's bipolar, he had actually been off of medications completely for a long time. He was, beside himself, being either anxious or depressed, and he couldn't sleep. He begged me to restart him on his quetiapine, and he's so much better now. Is it okay to keep him on it with all these side effects that we're looking at? I mean, he's so much more improved. He's not having any of these side effects that I've seen so far.
So you have to be a good osteopathic physician here. So we're talking, by the way, bipolar and not dementia. So, quintiapine is a fine medication in bipolar disorder. For some schizophrenics, it's the only drug that works. I'm talking specifically in dementia, but quintiapine, because of its histaminergic effect, can be a little more sedating, which is why it works well in bipolar. You just have to watch him, and you have to monitor for sedation, you have to monitor for rigidity, because his body is different than ours at 85. And you just need to make sure that you're monitoring and documenting well, and that's just being a good doctor. And he trusts you. And I think that the therapeutic alliance is incredibly important, and I think you give him a lot of comfort, you listen to him, and he's better. Isn't that what we want for everyone, right?
Steve, great conversation, discussion, topic, absolutely enthralling. But one of the things that I take away from this is, when you have situations with, let's call it egregious polypharmacy from the hospital, what is the best strategy to go ahead and communicate such things happening? Because it doesn't serve anyone any purpose, the patient, the hospital, anyone. But how do we as outpatient providers or just notification, how do we go about it? What's the best way to do that so that this type of polypharmacy can be kind of cut off at the knees?
So I didn't add that, but you asked the question, so I will. I knew the prescriber, so I called the physician at the hospital, and the physician hung up on me. At which point I called the hospital administration and asked for a case review, and that physician's no longer at that hospital. Because what the administrator called me back, they were very kind about that. This was not the only case, and they started seeing this pattern of what they called very heavy-handed prescribing, putting patients at risk.
I just wanted to know, after this lovely talk, do you have any advice for physicians, especially in our first 5 years of practice, about communicating with families and potentially other prescribers that we don't feel comfortable or will not prescribe things like benzodiazepines? I get a lot of family members asking for these medications, from the reasonable, like dad's agitated, and this works faster, to the very unreasonable. One patient asks me for oxycodone for sleep, and I have to explain to her that, no, we don't do that here. And she goes, well, in Florida they did, and I said, well, this isn't Florida.
Yeah.
So
No, you have to say, thank God this isn't Florida.
So any advice you have in that communication portion, cross-generation, millennial to non-millennial, would be very helpful.
So you will make a huge difference in your patients' lives and their families just because you've asked that question. So we teach our residents and our students that it takes no time to write a prescription, but it can take double or triple the time to explain to the family why you won't write the prescription. I find in my practice literature is very helpful. And really, the other interesting tool, and thanks to my very good friend and colleague, Dr. German, is drug testing. Because we don't like to talk about it. I sit on the AMA's Substance Abuse Task Force, and I brought it up there. You should have seen the head explosions of my allopathic counterparts when I brought this up. But families are diverting these drugs. The family may not want the drug for their loved one. They're looking for you to prescribe for them. And when you drug test your patient and surprise they have no opiates or no benzodiazepines in their system, but you look in the PMP and the drug's being filled, well, you got a problem. So I also find having articles and literature available on what the dangers are, they have to be appropriate. I'm not going to produce a Journal of Osteopathic Medicine article on benzodiazepine use and hand it to a lay family, but New York Times article, excerpts from radio programs. I mean, quick Google searches, you can pull up all sorts of quality stuff and scary stuff. But I think creating that alliance with patients, words will get out on the street. Number one, don't go to her if you're looking for prescription drugs, because she's not doing that, which I would pat you on the back and say, great doctor. Two, word will get out that this is someone who really listens and really cares and really takes time with us. And those are the patients you're going to want anyway.
Stephen, thank you for the talk. So I practice in a pretty rural area. As you can all tell by my accent, I am not from this area. But I go to 3 different assisted living / nursing home facilities, and I and my partner are the only 2 doctors that go there. So my question is with the staff. I get a call for literally any behavioral disturbance whatsoever. Patient was angry this morning. Can we increase the Seroquel? Can we increase the Ativan? How do I address this with the nursing staff who are looking for that instant gratification answer?
So it's a question we ask as well. And the question is, who are you medicating? Are you medicating the patient or are you medicating the staff? And I think 90% of the time you're medicating the staff. And it works in hospitals too. I see Dr. Zasanti nodding, and we've seen that when we were on call at nights at a certain hospital in South Jersey. But you can make yourself invaluable in that situation if you have the time by going in and doing in-service training with the nursing staff. And you get the administrator to buy in. And you bring literature in about why this isn't what we want to do. You take a deep dive into what kind of activities are going on. You may find there are no activities and the patients are bored. You may find people aren't sleeping because if you track nights they're not sleeping, they may not have eaten dinner or they may not have liked dinner, so they just picked at it. So, Ensure pudding, high protein snacks at bedtime may help with sleep issues. You really want to target facilities like that with non-pharmacologic interventions because a lot of times the patients are bored. Sometimes there are real problems going on and you do need some pharmacology. But the knee-jerk I find of most of the nursing and the staff in these buildings is more medication, more medication, more medication, and then you get this problem. But I think if you have the time, the opportunity to really make yourself an invaluable resource for those buildings is there. Okay. All right, thank you everyone.